Hi, my name is Katie Coleman. I'm a stage 4 kidney cancer patient, and this is a conversation between me and my medical oncologist, Dr. Pavlos Masau. I was diagnosed in the ER. We didn't know what my subtype was yet. And so I was curious what happens if you have patients that end up in a similar scenario where they come to see you and they haven't had a biopsy or anything like that to know what their subtype is yet. What is the process to work up those patients, and what are the next steps when they come to you?
It depends on how extensive we believe the cancer is. So, for example, if we have reason to believe that it is contained only in the kidney, and as long as we believe that it is not one of the more rare subtypes that tend to be very aggressive, like renal medullary carcinoma, then we may decide not to expose a patient to a biopsy. And instead, either if the cancer is too big, remove the whole tumor and either part of the kidney or the whole kidney, and then find out after doing that what exactly subtype the kidney cancer is, or do other procedures like burning the cancer or freezing it or ablating it, etc. If the cancer, however, appears to have spread to different organs, then we often choose instead to do a biopsy in that organ where it may have spread. And why do we do that? Because we have, let's say, two options. One is we can do a biopsy of the kidney tumor, and in this case, we may find that, yes, it's a kidney cancer, which we kind of knew already, that it's probably going to be a kidney cancer. Or we can do a biopsy of another organ, let's say the liver, or let's say the lungs, and find out when we look under the microscope that this is a kidney cancer that has spread to the liver or the lungs, which means that we don't need to do the biopsy on the kidney tumor and thus expose the patient to the risk of the biopsy. A biopsy, like every procedure, has risks, and so we try to minimize those.
That's interesting. So I ended up having a biopsy of both my kidney and my liver when I was obviously at a different institution at that point. I'm curious how often you end up seeing that, where they have biopsies of both.
That's, in your situation was quite unique in the sense that it was necessary to have a biopsy of both the primary tumor to convince ourselves that this is an oncocytoma, and it looked like on imaging that it is an oncocytoma, but then when you do the biopsy on the liver and find out that it's also an oncocytoma and it looks exactly the same, and that's another key aspect, that it looked exactly the same, that's an immense amount of information tailored to your case. And I think that teaches us that there can be no, one approach that just applies to everyone. There is no one-size-fits-all rule. But in general, I would see doing two biopsies when, for example, for whatever reason, you only did a biopsy in the kidney tumor. Maybe initially people didn't realize that there were areas elsewhere that look suspicious. If that happens, and we know that the biopsy of the kidney tumor looks like kidney cancer that could spread somewhere else, then we might want to do a biopsy in the other organ as well before committing a patient to the idea that they have a stage 4 metastatic cancer, because that leads to a whole different trajectory and considerations. Or sometimes we might do that when we think that a patient may have more than one cancer. And I've seen that. I've seen sometimes patients who have, even at the same time, 2, 3, even 4 ones. A patient who had 4 different cancers at the same time that were diagnosed.
And those are separate primaries, right?
Yeah.
For those?
Yeah.
When you're doing biopsies of multiple organs, this is something I've always wondered because I saw it in my pathology report, that when they're describing the two different biopsies of mine, that the cells looked exactly the same. Is that usually what happens when it's basically spreading from the kidney to another organ? Do the cells, if you have two biopsies and it's from metastatic spread, do they always match like identically like that?
Not always. There, again, no perfect answer. There is always, different situations and different things. Sometimes, for example, in kidney cancer, you may have the primary that looks like, let's say, clear cell kidney cancer, the most common one. And the cells look clear under the microscope. But then within that primary tumor, the cells evolve, they mutate. And it is that process of the cells evolving that allows them to figure out eventually a way to escape and go to different organs. In fact, they have to go through a whole journey to do that. They have to survive being in the bloodstream. There's all these mechanical forces that, threaten to kill those cancer cells. So they have to evolve to survive that. And they have to evolve to go to different organs. And so what happens is that once they go to a different organ, let's say the lung, that process of evolution may have made them look quite different than the primary tumor. In fact, the fact that in your case, the liver lesion looked similar to the kidney one did suggest that your cancer didn't tend to evolve so much so that it would start demonstrating very, very unusual behavior, which made, thankfully, your situation much more tractable. Because if we were dealing with something that were constantly rapidly changing, then things would have been much different.
Yeah. When you head for a biopsy, I know one of the concerns that I had when I was going for my biopsy was wondering if it's safe. Curious if you can talk about the safety around biopsies. I know for me in particular, what I was worried about was seeding. I was trying to look up what a biopsy was like. And so I kept seeing articles or actually even in support groups, people talking about seeding. And so it was something that I didn't quite understand. So I was wondering if you might be able to kind of explain what that is.
Yeah, and biopsies generally do tend to be safe, especially when they're done by experienced people. Those are the situations that are operator dependent. And those are the situations where I prefer that people have their biopsies done by teams that have done this a lot, because no matter how safe a procedure is, and biopsies generally are safe, there can still be complications. Potentially, we want to minimize those. Those complications might include things like bleeding, infection, etc. But sometimes, rarely, they do include the potential for what we call seeding. And what seeding is, it means that essentially you do the biopsy, and while the needle is there, while it's been taken out, cells that are in the needle start seeding the area, the tract that is generated by the needle going in. And essentially, those cells, first of all, in order for this complication to happen, you need to have the very rare event whereby the cells actually escape the needle. The also rare event whereby the cells learn to survive in that tract, and the rare event where they actually not only survive it, but they start duplicating and becoming an actual new tumor along that tract. Now, that description of those mechanisms also suggests that biology plays a role, which explains why some cancers have a higher propensity to seed than other cancers. Within the kidney cancer spectrum, the one that does appear to seed the most is actually papillary kidney cancer. That's something that is not necessarily widely known. It's extremely rare, regardless. Like even within papillary, the chances that a biopsy in a patient with papillary will have seeding are very, very, very low. So I think that patients with papillary kidney cancer should have a biopsy. But once you see seeding, if I am asked, if I'm shown a patient with kidney cancer and they have had tumor seeding and I'm asked to bet what type of kidney cancer that is, I would bet more than 95% of times this is actually papillary kidney cancer.
I've heard that HLRCC is another one of the subtypes that isn't biopsied super often. Does that kind of fall into that same category?
It's a great question because it connects with another important concept that I've heard a lot of patients ask, especially recently. It's actually a good problem to have, the fact that we're becoming much more granular with describing the different types of cancer. So it used to be not too long ago that we essentially had one type of kidney cancer, and then there was some evidence that there were others, and essentially kidney cancer got divided into clear cell and then everything else, and then that everything else, the non-clear cell bucket, turned into different subtypes like papillary and chromophobe, the two big ones from the non-clear cell spectrum. But now we're learning that if you take the papillary kidney cancer bucket, there are actually a lot of subtypes. It's not homogeneous. And that happens even with clear cell kidney cancer. As we become smarter about understanding clear cell kidney cancer, I can assure you that we will divide it into new subtypes. And sometimes it's a good idea to focus on the specific nuances of its subtype. That's what we call the relevance. But sometimes we may want to look at things more broadly. And at that point, we change our resolution. Instead of being granular and saying within the papillary subtype, here is HLRCC, because that's what happened. We have the broad papillary of category of papillary kidney cancer, and there are many subtypes like HLRCC, NF2 deficient RCC, other types of papillary phenotypes. Even RMC at some point was considered to be part of the papillary spectrum. Yeah. If we look at the resolution, the lower resolution, the broader one, HLRCC is a papillary renal cell carcinoma. So it is an intriguing question that remains to be answered more fully now that we understand all of these nuances. Is HLRCC one of those papillary subtypes that has that propensity to seed? Out of an abundance of caution, I think it's better to be safe than sorry, so you better to be careful. But it is, in my mind, an open question to understand. Maybe there are certain papillary subtypes that are more likely to seed than others. I have not, the situations of seeding that I have seen personally thus far have not been exclusive to HLRCC. So I suspect that it is, but they have been almost always papillary. I suspect that it's a broader phenomenon associated with that broader type.
So my next question on the seeding part. So when it does seed, I know when I was trying to look all this information up as a patient and I was super worried about seeding, one of the things that I couldn't quite figure out is, do you consider it the same, like if you have seeding that ends up happening, do you consider that the same as metastatic disease? I eventually thought I found that it's not treated quite the same, but I'm curious what the actual answer to that would be.
The answer is, again, it depends. Mm-hmm. It sometimes, it's useful to have certain definitions, as I said, papillary. And then you go deeper and you realize, it's not just papillary, it's papillary that is HLRCC because it has this mutation in the F8 gene that defines the HLRCC subtype. In the same manner, you can call a seeding event as a metastasis because it is. It is cells that have spread, and sometimes they're not continuous. It's, they have spread and they're growing without being connected to the primary organ anymore. Mm-hmm. So in that sense, it is metastatic. But is it really the same as a metastasis that happened whereby the cells evolved to go to the bloodstream, survive through that circulation, escape, go into an organ, survive there, and divide? No. Whereas if you look at it through a certain lens, you can call it metastasis, you can call it spreading. Undoubtedly, once you go deeper and think of the mechanism, it's a very, very different type of spread than others. Yeah. And that guides your management as well.
I was curious about that specifically because I feel like the few studies that I did read when I was reading about it, I think that they had resected the tumors from there and those people didn't have reoccurrence. And so it had brought the question in my mind of, is it the same as just regular metastatic? They weren't actually kidney cancer cases when I saw that. So when I got my biopsy results back and I read my pathology report, my first pathology report labeled my tumor as a metastatic oncocytic neoplasm. And I remember Googling that term and trying to figure out what it was, and metastatic oncocytoma came up like once. And then I was trying to figure out what an oncocytic neoplasm was. And when I was looking for information, a lot of what I found was just clear cell and non-clear cell. And so I was trying to understand the buckets that kind of fell into the non-clear cell category, since that's where I would have been falling. And that eventually kind of pushed me to look for a second opinion, is because I realized that I was falling into most likely this non-clear cell, more rare type. How important is knowing your subtype, and are there different treatments for the subtypes? And a follow-up question to that would be, has that changed over the years as far as treating them differently?
Extremely, extremely important. I cannot emphasize enough how important it is to have that knowledge. And sometimes it's practically impossible to classify the tumor because we don't know enough yet, no matter what we do, and we call this unclassified kidney cancer. But whenever possible, it is absolutely essential that we know the subtype, and usually that might require a second or even a third opinion in specialized centers that are able to distinguish between those subtypes. And the reason why it is so important is because, exactly as you said, the management can be vastly different. For example, renal medullary carcinoma, which is a non-clear cell subtype, is treated in the exact opposite way than just about every other kidney cancer. So if you just call a patient with renal medullary carcinoma, which used to happen in the past as, just a non-clear cell, and you just treat it in this blanket way, those patients will die within 6 months from diagnosis. That's an extreme scenario, but it's real. The other aspect is not just the treatment, but sometimes an aspect that in oncological decision-making we don't harness enough is prognosis. And I think that prognosis is very, very important to patients and their decision-making and how they structure their life after diagnosis. So certain subtypes, like chromophobe kidney cancer, have a different prognosis at baseline, all other things being equal, than other subtypes like papillary kidney cancer or renal medullary carcinoma or translocation kidney cancer, HLRCC, etc. So that is also very important.
Yeah. So once a patient knows their subtype, or I guess even, I actually have a question further back from that. Are there any pathologists or any path reports that ever just say non-clear cell, or do they usually go into an explanation of what subtype it falls into? My question there is basically, what's the best way for a patient who's been told that they have non-clear cell? What's the best way for them to find out what subtype they have?
It should be on the pathology report. Obviously, different institutions may have different standards. I strongly believe that you shouldn't just say non-clear cell. And if you do, you should say, and be honest, that it is an unclassified one. And so at the very least, if the pathologist doesn't know what it is, but know that it's not clear cell, they can call it unclassified non-clear cell, like broader category non-clear cell, but we cannot say what it is. At our institution, we always say it is this subtype or this subtype specifically, with even more details, including, and in most pathology reports at other institutions as well, they will say this, it's stained positive for this stains and negative for this. This is useful information because it gives you clues on what it could be. Even if formally, in some rare cases, it is an unclassified one.
So I think when I read my path report from my original institution, mine did have it was listed as metastatic oncocytic neoplasm, but it was the comment section in there that kind of really led me, because it was very thorough in that it looked like it was kind of unclear what it was. And so that led me to seeking second opinions. And when I was looking at second opinions, I started looking specifically for academic centers, because I figured that they might be a little bit more specialized than community for what I was looking for in particular. I was wondering if you could describe the differences between academic centers and community centers, because I do think that there's pros and cons of both. And I think a lot of patients may not know the differences between them and which one might be better for their scenario.
I think they're both extremely important, and they serve the communities in their own ways very well. I admire the fact that community oncologists are capable of triaging so many different cancers, making sure that, patients with many different disease entities and different neoplasms, different cancers are treated appropriately. And, they follow certain high quality standards. At the same time, what academic centers can offer to different degrees, depending on, how specialized the academic center is that specialized understanding about its subtype. And this becomes progressively more important the more rare a disease is. And so for situations where you have a very rare cancer that defies the textbooks, I think that it will help immensely to have a second or a third or even a fourth opinion at highly specialized academic centers.
So for my case, I obviously fell into that rare case. And so that's kind of what I was looking for. I was also looking for a center. The center I was at still technically is an academic center, but they didn't have any clinical trials available. So I know when I was switching, I was also switching to see if there might be any clinical trials available. My question would be, for the more common types of kidney cancer, like clear cell, for example, would a patient have access to the same treatments if they weren't in a clinical trial just through like a community oncologist for some of those that they would at an academic center?
Community oncology centers do run clinical trials. Sometimes they may be more multi-center umbrella type of trials, sponsored by industry. But there are community centers that have access to a good portfolio of trials. Academic centers do tend to offer more specialized trials as well. Very often, these are trials designed by the physician scientists in the centers themselves. That may make them a little bit more biology driven, more tailored to specific situations. Clinical trials can be very important during patient care, as long as they're used wisely. Again, there is no perfect rule, no one size fits all that says you should always enroll on a clinical trial or you should not always enroll. I think there is enough regulation to make sure that at least, there is safety and that the trials are ethical. You're not going to do something grossly unethical when somebody gets enrolled in a trial. But sometimes a patient will really benefit from being enrolled in a clinical trial, and other times it's not a good idea. And through a patient's course, this is something that we discuss a lot: when to implement clinical trials and when not to do so.
Yeah, I think that that plays in well to my experience at MD Anderson. So when I first came down, when we had another read in my pathology, it actually did end up lumping into the unclassified oncocytic neoplasm, was listed in that one. And when I was first trying to figure out treatments, I was offered a clinical trial. And when I had looked at the NCCN guidelines, the snapshot to see kind of what fell into the non-clear cell bucket, I had seen that there was a drug for Sutent, and then clinical trial was also listed in the top ones of preferred options, I think is that first category. And so I was looking into the trial to see if that was something that I wanted to do or not. But both drugs were available to me outside of the trial. And so I personally decided not to enroll in that one. But that's what I appreciated about the fact that it was a discussion of like, here is the trial, here's the drugs. And then that was a decision that I could make as a patient, deciding which route I wanted to go. But one of the things that brought up for me is kind of going back to the subtypes, and you mentioned about kind of there's the larger buckets and then there's the smaller buckets that go down into each subtype. Two questions there. Is there a reason why there's not more trials for non-clear cell types of kidney cancers? And then in your opinion, which trials, I guess, are more beneficial? Is it more beneficial to have more patients to be able to actually accrue the trial, or breaking them out by subtype because they're so different from each other?
Well, once again, my answer will be it depends. I have to admit that I strongly support the development of clinical trials that are biology driven and tailored specifically for its subtype. And there was the misconception, and maybe there still is, that this is not possible for some of their more rare subtypes. But I think that we have been proving in the past few years that it is possible. You can develop clinical trials that are specifically designed for specific subtypes. And the reason why this is so important is because its kidney cancer subtype is very different from the other. Their biology is different. When you look under the hood, it's a completely different machinery there. So while in some cases it might make sense to have a more basket approach, or a more umbrella approach where you're using, this therapy and you try different different subtypes across subtypes, the differences in the biology between the kidney cancer subtypes in particular are so remarkable that I feel that we will gain much, much more, and our patients will benefit so much more if we develop and they enroll in trials tailored to their disease. And one of the reasons why there was resistance to that idea is the misconception that you need a lot of data in order to make reliable inferences for a specific patient. Now, if that were true in your case, then we would be in trouble. Yes. And that misconception can generate desperation. It can make you, somebody it's like, oh my God, my situation, my cancer is so rare, it's not even in the textbooks. What do I do? But once you realize that this is not exactly true, sometimes, in fact, the more data we have, the more surely we can fool ourselves. And we can actually make tremendous mistake while being certain that we're doing the right thing. Once this is understood, and once it is understood why that happens, you can actually flip the narrative and realize that every single patient has the most rare disease in the world. Only they have it. And so that is the reality. And how do we address and make this situation, this challenge, and make decisions for each patient? By thinking about what is driving each patient-specific cancer? What are the mechanisms? What do we understand about each patient? And to do that, we can use various sources of knowledge, like we did in your case, to make reliable inferences that can increase the odds that you can get a good outcome. The exact same philosophy or framework applies to clinical trials as well. You can design and advocate for and champion clinical trials specifically for a rare subtype, and you can enroll 10 patients on it, 20 patients on it, 30 patients on it, and make a big difference in this subtype and in this patient population.
All right, so I think we applied some of those same concepts to my case, which I think you touched on. So originally, the first treatment that I think I was offered at the other institution that I started at was immunotherapy plus a TKI. And then once I made it down to MD Anderson, we ended up putting me just on a TKI without immunotherapy. My question, using my case kind of as a springboard there, is what was kind of the logic that went behind putting me on just a TKI instead of adding immunotherapy to it?
And this alludes to what we call the fundamental problem of causal inference, whereby we can never know what would have happened if you were treated with the first recommendation. Yeah. It is possible that maybe that first recommendation would have brought the same results or better. The only way to know that is if we could go back in time and having the knowledge of what happened when you got the one TKI, see what would happen if you had gotten the combination with immunotherapy, which is impossible, which is a challenge across life. And so the best that we can do is to try and create rational, coherent strategies using our best understanding of the mechanisms and the biology behind each disease. And so in your situation, your cancer shares a lot in common with a more common but still rare kidney cancer, chromophobe kidney cancer. And it's not just the fact that it shares a lot of things in general in common, it shares a lot of aspects that make chromophobe potentially resistant to immunotherapy. So chromophobe kidney cancer is remarkably resistant to immunotherapy. And there was a very good reason to expect that the same would happen with oncocytoma. And so again, even though you had this ultra rare tumor, we can still actually use outside context to make rational inferences about you. Mm-hmm. And if we gave you immunotherapy, sometimes this can cause side effects. And now these side effects sometimes can be severe. And these side effects may have even prevented our ability to do surgery down the line, etc. So there was not a good enough rationale justification for including the immunotherapy, but there was a rationale, at least for the TKI, because the mechanisms that potentially drive, and it has to do with the oxygen metabolism of chromophobe and oncocytoma, are potentially targeted by this TKI, although not perfectly, which is exactly why we need therapies, which don't yet exist, but hopefully they will emerge in the near future, that are tailored to that biology. But this was the best we had, so we had at least some rationale that those therapies could work, and some rationale that immunotherapy would probably not add much efficacy and potentially cause side effects, which is the reason why we advocated for using simply the TKI.
And that played out pretty well in my case. So I did end up having a response, and we saw some of the tumors shrink, which then opened up the discussion for surgery, which you kind of alluded to. And so my kind of using my case there as an example of what was it about kind of the response to treatment that would open up surgery as an option in my case. And then also curious if the same options would be available for a different type of kidney cancer. Would the decisions have been the same there if I had another subtype?
The decision would have been different if you had other subtypes. But that would have been the case because of the different biology. And that different biology, or putative biology as far as we can understand it, declares itself by different clinical behavior. What happens is that when you have, let's say, the most common kidney cancer, clear cell kidney cancer, by the time it goes to the liver, it will have gone also most likely to many other areas. That's the way it behaves. And that's based on its biology. And so what that implies is that unfortunately, it is much less likely to render a patient disease-free if their clear cell kidney cancer has gone to the liver. However, with chromophobe kidney cancer, which we use as a cousin for your case to gain information, we should always be mindful that you did not have chromophobe. Yeah. And so we have to keep an open mind and say, but there is those similarities. Are there enough? And here is how we approach this. Chromophobe kidney cancer does have a propensity to spread only to the liver without going anywhere else. And this has translated into situations whereby, even though it has spread to the liver, which for many other cancers, that means we can no longer do surgery. With chromophobe, you can do surgery and the patients remain disease-free for the rest of their lives. And so now that's clue number one. Clue number two is the fact that the extremely rare situations of oncocytoma that have spread, they have spread to the liver. And we had evidence, including by the team at NCI, that if you do surgery in those situations, you may render patients disease-free for the rest of their lives. So this is orthogonal evidence, two different pieces of evidence telling us that in your case, surgery to the liver, even though in general, for non-clear cell in general, it's not a good idea broadly, in your case, it would have been a good idea. Now, at the same time, again, we have to keep an open mind and be strategic. That's the way to maximize the odds that we're going to get a good outcome. And what does that mean? We want to believe that everything I just described to you is true. And as it turns out, it has panned out thus far. But we want to keep an open mind and hope for the best, but be prepared for anything. That's how we build our strategy. And so in your case, we also wanted to have a systemic therapy option that we know could work no matter what. Like no matter what we found in the liver, in case we needed to pull that card and use it, even if we didn't know whether you had more cancer or not. And so we wanted first to gain evidence that we had a therapy that could work. So it was two advantages of starting with the systemic therapy, the TKI. Number one, learning that we have, getting objective evidence by imaging, even early imaging, that there is some response so that we can use that for the future. Number two, also at the same time shrink the cancer and potentially eradicate cancer cells that are hiding that we cannot see, because there's going to be few of them. So if we eradicate them, they'll die. You sterilize those areas so that the surgery can happen afterwards. Now, the counter argument, and that's again thinking, you have to think 5 steps ahead. The counter argument to that would be, well, why do you want to expose the cancer to this systemic therapy early on and allow it to potentially evolve into something that's resistant? But remember what we discussed in the beginning, that your cancer is not the type that tends to mutate a whole lot and divide and potentially create that resistance. Now we're speculating a lot. That's because we're thinking 5 steps ahead. But it's a good idea to think before you act. And that was the rationale behind the strategy that was employed for you.
Okay. I think that touches on, so I know something that I had a lot of confusion on, especially when I was first diagnosed and even shortly after I made it down to MD Anderson, was the fact that I didn't have any surgery options available. And when it was communicated to me, it was kind of communicated to the same, alluding to the same concept of like, if it's gone to the liver, it might not be worth it yet. As well as part of my confusion was I was a part of a lot of support groups online where I saw a lot of patients who at least had a nephrectomy to remove their kidney. And then they were treated with systemic treatment afterwards. And so, I know one of the questions I had was trying to understand why my kidney was remaining with the tumor and why it didn't come out, even if we weren't removing the disease in my liver. And I think you kind of talked about that for my specific case, but I was curious if those guidelines have evolved over time. That's something that I kind of learned later on as I've seen more and more patients have their tumors, still have their kidney, and they don't get the nephrectomy and they start systemic treatment first. And so I'm curious if the guidelines have changed at all, or if it's more important to consider the subtypes in those scenarios, or kind of what the different factors at play are when deciding that.
It's a good question, and it depends on the guidelines, and I'm not sure, if those general guidelines have enough resolution to get into those very nuanced type of questions. I know for a fact that I think less than a year before we saw you, we had published a paper on the management of non-clear cell kidney cancers, where we very, very specifically reinforced that there should not be just a basket approach, that you're using the same approach for every kidney cancer. And we very much highlighted the fact that if you see a chromophobe kidney cancer that has only spread to the liver, consider doing a localized therapy like surgery, radiation, ablation, other approaches to that area. Do not take it as the same as seeing a liver metastasis in clear cell or any other subtypes. And that alludes to your question about should it be subtype specific? Absolutely. And the exact same consideration applies to should we sometimes give systemic therapies before we do anything else? Absolutely. And it depends on the subtypes, it depends on the situation, it depends on so many things. This is why, unfortunately, guidelines can give a broad idea of certain things that you can and cannot do, but you cannot just use the guidelines to specifically take care of any specific patient, because every specific patient has their own situation, goals, needs, values, and even comorbidities, other illnesses, which you have to take into account. So what ends up happening in the end is, especially if you're receiving specialized care, is that the management approach has to be tailored to you and for you. And that means that not only is the overarching plan that we make has to be coherent based on the available evidence and based on an understanding of how your disease is going to behave if we do X, Y, and Z, but also take into account your goals and values. So there is no perfect answer, for example, that says, oh, I should do surgery in 6 months versus 7 months or 5 months or whatnot. And so sometimes this is something that we individualize, and it's very person dependent. Sometimes a person may want, for example, to do imaging after 3 months, even though probably we could get away with doing it in 6 months, or the opposite. And that's very, very important to contextualize, because patients are full human beings. They're not just, the cancer. So we have to take into account those goals, those values, those considerations.
I think that plays well into the next part of where my journey has kind of led, or my diagnosis. So while I was getting a second opinion from MD Anderson, I also was getting a second opinion from the NCI, who had offered surgery for me as well, but they were offering surgery sooner. And I know that's a discussion that we had. And for me, my biggest priority was to get the tumor out. I could feel it. I would lay on my side and it would poke me in the side. And so it was a constant reminder for me. And so when surgery was offered sooner, that was definitely something that I was interested in taking up. And we kind of discussed there together. So when I finally went for surgery and I was in those discussions with the NCI, it kind of fell all into the same bucket of, it's not necessarily kind of the standard of care, but we decided that that was a risk for me personally that I wanted to take. And so I went through with the procedure at the NCI. And one of the things that I want to talk about there is kind of how that decision process came to be. Because I think it can be kind of tricky for patients to figure out how to navigate those conversations. So I was having a conversation with you at MD Anderson about, I was on treatment and we were trying to get me to surgery kind of later down the road. And when surgery came up sooner, that was something that I appreciated, because I knew that you were evaluating my goals and priorities. So when we had the conversation, I kind of told you frankly of, I really want to get this surgery, and then was seeking your opinion. And so I guess my question there is, what goes into the process of a patient communicating that with their physician? What is the best things that they can do to make sure that a physician understands what their goals and priorities are when it comes to treatment?
Be frank and advocate for yourself, and just be open. I think that the vast majority of situations, I think that we're on the same wavelength as patients, and we should be. Yeah. And even if we're not, patients' needs come first. Now, in your situation, the other thing that was a big advantage is that the NCI team is a very, very trustworthy team. Sometimes when we do things that are outside of the norm, and are very, very operator dependent, and surgery or ablation is certainly one of them, you really want to make sure that you have a highly specialized team. And the NCI team were highly specialized, which was very comforting. So when you mentioned that they had already offered you that option, I felt that is great. In fact, it was better, since it was already being set up by a trustworthy team, to do it rather than going and recycling the process to do it at MD Anderson. And especially, we could have waited longer, but at the same time, one can say we could have waited longer. But at the same time, maybe it wasn't just your mind that was saying, I need to take it out earlier. Maybe you were experiencing side effects from the systemic therapy. It's not just the pure subjectiveness. When a patient tells you, I am more inclined to do this, maybe it's also their body talking. And that's why it's important to take it seriously. And since that option was a very plausible one. Sometimes, a patient might tell you something that, is not right and it can be harmful to them. And in that case, it's your responsibility to say, no, that's really not a good idea. But in this situation, this was a very plausible thing to do, which was why I certainly encouraged it. And thankfully, we've had good results.
Yeah. So I went through a surgery, and obviously that all went well, thankfully. And after surgery, we noticed that we didn't quite get all of the spots, and I did have growth in a couple of the tumors, and then went back and we ablated some of those tumors, and that was done at the NCI again. But after that, I have just been on active surveillance. And so kind of using my case as a springboard again to talk about kidney cancer as a whole, my question is, why did we decide to put me on just active surveillance afterwards? And would that decision be made if I had a different subtype?
Yeah, absolutely. And by the way, that scenario that played out exactly highlights how important teamwork is and how important it is. It's not just for a center to just have one good surgeon, but a whole team. And what happened here is that the NCI had, and we knew that ahead of time, a whole team that could be employed to help out in every aspect: the surgery, the ablation, the blood transfusion, other aspects that were very important. It's teamwork always. And as you said, the decisions that we do afterwards depend on what happens, on what we see in the pathology, what we see on imaging immediately afterwards, and on the patients as well, goals and values. We knew, for example, that the TKI would impact your quality of life. Mm-hmm. And we had no strong evidence after the procedure that there was any cancer remaining. Mm-hmm. So why impose upon you something like a systemic therapy and all of its side effects when for all we knew, you were cancer-free? Mm-hmm. And the more time has passed, the more strongly we believe that. Mm-hmm. And so now, if this was a different subtype, for example, a subtype that is more likely to, very quickly spread to the lungs, etc., the decisions would be much different.
Mm-hmm. That is, I know that immediately after surgery, I was glad not to be back on systemic treatment because of the side effects that I was experiencing. But I know I also had a lot of anxiety about going on active surveillance and not doing anything. And it's something that I see a lot with earlier stage patients as well. And I think a lot of that comes from just kind of the culture around cancer. And there's kind of this whole mentality of you've got to fight cancer and you've got to be actively doing something. And so I know that for me personally took a while for me to understand that sometimes doing less is more. And I love being on active surveillance now. And I feel like I have an amazing quality of life because of it. And so I'm glad that we did that in my case. But I do think that that's something that patients in earlier stages often deal with as well too, is because when you can't see the cancer that you're going after, and you don't know if it's there or if it's going to come back, kind of just sitting and waiting to see what happens can definitely cause some anxiety. So you might have already answered this, but if I had a different subtype, so say we did the exact same surgery for some reason in clear cell, which we talked about probably wouldn't have been the case, would you still have recommended active surveillance for me afterwards instead of going on a treatment?
Not only if there was a different subtype, but also if there was different behavior of your cancer to the initial challenge with systemic therapy. And this was the advantage of timing this and doing all of this in a stepwise fashion, is that it gave us knowledge about your cancer. Like, even though you had an ultra rare cancer, we learned from it about it. We learned how it behaves when we give it systemic therapy. And that was comforting because that told us that even if we let you be on active surveillance with no therapy, if the cells started dividing again, we had tools to treat it. That's very important, and that makes a big difference. Now, as you said, this can definitely create anxiety, and it is part of the physician's job there to gently nudge towards the active surveillance, of course, by explaining the pros and cons. And as you said, a big thing to keep in mind is that sometimes indeed less is more. And at the same time, that active surveillance is not ignoring, because if we were ignoring, we wouldn't be doing the imaging. Yeah. We're actually doing imaging. We are doing things. We're just not overdoing. And thus far, it's panned out really well.
Yeah. When I look back on my experience with it, I don't know, because you communicated all of this to me, I think, when we talked about not going on treatment. And I don't think it was, and even before I actually started treatment, I think it took me a couple months to even start treatment in the first place. And I had a lot of anxiety about the fact that I wasn't starting treatment yet. And I don't think I got the perspective of what the difference could be until I was on systemic treatment and then coming off of it and realizing what the difference was for me personally in my life and kind of where I wanted to balance that. And so I think that kind of goes back to each patient's goals and what they want. And for me, that's kind of the quality of life that I have right now because we've been able to be on it, or I've been able to be on active surveillance. So you mentioned if I ever had a reoccurrence, like we know that I responded to the first treatment that I was on. My question would be, if I had a reoccurrence, would that be the treatment selected? And if not, clinical trials, when we're talking about clear cell again, where do those come into play when you're talking about like reoccurrences? Well, I guess we'll use my case as a springboard and then kind of talk about clinical trials that are available for non-clear cell in general.
Yeah, and I hope that there will never be a reoccurrence, and there likely will never be. Yes. But even if there is, we will again take things into context. We will think where it is, how extensive it is, what are the tools that we have available at the time, etc. We are not going to commit ourselves to just a single strategy. We have the tool, the TKI as an option. We leave it in our toolbox, and then depending on the situation, we'll make a strategy that is coherent, that is able to be adapted as things continue. So essentially, the way it's a good idea to plan strategies that allow you to course correct depending on what happens. And again, it's the idea of hoping for the best, but be preparing for anything. And now, I do hope that in the near future, we will have more specialized therapies that are tailored to the biology of chromophobe kidney cancer and oncocytomas. And I do think that towards this goal, clinical trials, dedicated clinical trials will play an immense role. Even with, let's say, patients with renal medullary carcinoma, that is a subtype of kidney cancer for which we in our group have developed specific clinical trials proving that it is possible to do something like that for such a rare cancer. We don't always blindly say, come and get on the clinical trial. We incorporate the clinical trials as part of their strategy. Sometimes you want the patient to be enrolled on a clinical trial because it's the better thing for them to do. Other times you want to wait. And the same exact thing would happen in your hypothetical scenario as well.
So I know you've had a lot of success with RMC trials or getting them to have trials, and RMC is actually more rare than some of the other subtypes like chromophobe kidney cancer, for example. What are some of the hurdles there as to why some subtypes might have more clinical trials available than others? And is there anything that patients can do to help incentivize more trials to come along?
So a big hurdle is that misconception that you can only generate reliable knowledge from big data from very common tumors, which is a mistake. But it's a misconception that we've been trying to change because it can create resistance when we are trying to convince folks to support such clinical trials. I think that this is a big aspect. And other important aspect, as you said, is championing. And there needs to be championing both by the clinical and research team, intense championing. And you will get a lot of no's. A lot. Like you have to fail a gazillion times in order to get a single trial. And even that single trial, you have to work extra hard for it. But it's worth it. And that championing includes the patient communities. And this is something that the renal medullary carcinoma, the RMC community has done really well and made a huge difference, whereby they organized themselves and they advocated a lot. And they said, we want research for this cancer. We want to turn it from something that's invisible, and it was really invisible, to something much more visible. And in the same way, in the chromophobe community, the patients can advocate for themselves and say that we want to champion trials specifically for chromophobe. Not just, do a blanket non-clear cell trial, enroll 5 patients with chromophobe that, are not in a very specific, well-organized, well-defined way, and, gain mostly noise out of it. No, specific tailored therapies trials for this disease are feasible and they're necessary. And in fact, we have to be ready for these trials to fail, because actually it is from these negative trials, so-called negative, that we will get to the next steps. Very often, it is by something not working, as long as when you try it, it's a coherent. You have a reasonable strategy, you implement it in a trial, and by being aware that the trial may fail, you also create fail-safes. And what are these fail-safes? You make sure that you do biopsies, that you collect samples, that you do a lot of things to identify how does this therapy change any mechanisms. And if it didn't change things that you expected to, why? And by answering these why type of questions, that's how you made a difference. In fact, in the RMC trials, at least one of the trials that was negative, completely negative, ended up being one of the most informative. And what it ended up doing is that it reversed our paradigm on how we think for patients with RMC, and it has genuinely improved the outcomes of patients with RMC, not through the trial itself, but through the knowledge, not the strategy of the trial, but through the knowledge that it generated that we then applied as so-called standard of care. It became the standard of care for this cancer.
So using RMC as an example, one of the things that I came across when I was first looking at clinical trials, even for unclassified, which I think was the only bucket that I really kind of fell into in some of the trials I was looking at, was a lot of what I heard is that it's difficult to recruit for those trials. How do you get enough patients in those trials? Do they have to be seen by that institution that's holding those trials? Or how do you even get enough patients in order to have a trial.
Yeah, and that's an excellent point. And one big challenge that we encounter with such trials is funding. And what happens is that funding is scarce, and every time that you're trying to add an institution to the trial, you're almost essentially doubling the budget. And we barely have enough budget for one institution. Hopefully this will change in RMC. I expect that by 2025 we will have multi-center trials for RMC. But to begin with, realistically, very often, though, trials may need to be either within one center or a small community of centers so that they're affordable and feasible. And what happened with the RMC community is that as they organize themselves, patients would contact them and they would say, oh, this is the place that actually has dedicated research for RMC. This is where knowledge is being generated, including clinical trials. Go there. And even if patients could not come because of logistical or other challenges, their physicians would contact us, and they still do. That's still happening. And we would make sure, to the best of our abilities, that we share knowledge that can actually improve the outcomes of these patients. And, that is very satisfactory. There are patients that with RMC that I have never met in person and that are doing really well through this kind of communications with their physicians. Unfortunately, and that's a key aspect, it is very important that it's a physician-to-physician communication. Sometimes, as much as I would want to give advice to a patient that I have never met, if I do that, I am much, much more likely to cause more harm than good for many reasons. And this is why it has to be a physician-to-physician communication, which is what we have been doing with RMC, and it has been working very well. The patient community as well supported each other by telling patients, these are some ways through which you can have better travel access, you can have places to stay, etc. That also made a tremendous difference in allowing patients to be enrolled on clinical trials.
I think that all of that kind of, to me, just all speaks back to kind of what we were talking to at the beginning of the importance of patients knowing their subtype, so that they can champion behind these things. We've established that I don't have chromophobe kidney cancer, but for example, I champion behind chromophobe kidney cancer. And I'll say, as a patient just with a rare kidney cancer, even in the time since I've been diagnosed, it's been incredible to be able to see that community come alive, and see what an impact it has. Because when I was very first diagnosed, I had lots of people that told me, you have a rare cancer. Rare cancers just don't get researched. And sorry, that's just the way it is. And I had no idea the impact that could be made with kind of just a small group of people kind of championing something. So I admire all the work that you've done on RMC. And I think that it's important that patients know their subtype, so that they can help their own treatments. But I also think that it helps coordinate the care, kind of as you just mentioned, because it can help their physicians coordinate with the ones who have seen it more often, or they can get to the centers that have the expertise.
Because of how the chromophobe community in recent times has started to advocate for itself, and it is something that now we hear, we became more sensitive to that as well. And it is only because of that less than 4 weeks ago, we were contacted by a company that may be interested in opening a plausible clinical trial specifically for chromophobe. Now, that doesn't mean it's going to pan out. Yeah. I told you already. You get a lot of no's, and a lot of things end up not going, anywhere. But it's a start. And that communication, for example, would not have happened without that advocacy from the chromophobe community.
That's awesome. Even the fact that those conversations happen, that's the groundwork of how you make progress, yes, I'm sure.
Exactly.
All right. Well, I think we'll wrap up there. I appreciate all of the questions and discussion that you've had. I hope that this will be beneficial for other patients so that they can learn more about their own disease as well.
I hope so too. A pleasure talking to you today.
All right, thanks.